We are finishing our section on the lower limb. All the muscles in the lower limb, other than the pelvis that we talked about yesterday, we're going through today. And I'm doing it a little bit differently, where I'll give you highlights on a slide while teaching to the app. So the overlay will be present with the highlights on the left, and we'll go through hip, knee, ankle joints, the muscles that span those joints, and their main actions. Some muscles will have multiple actions, and I'm only highlighting the main actions for you here. Other than that, let's get rolling. So we are looking first and foremost. You have a lot of other slides that I'm going to go through to help go through some of the online 3D aspects of it. So follow along, make notes in those pages on those textbook figures. And as we go through, if you are confused or get lost, stop me and we can work on the pace and work on the material. So muscles first and foremost of the hip that move the femur. So hip flexors, hip extensors are what we're looking at first. And then also in this section, because a lot of the muscles that move the tibia and the fibula that articulate the knee originate from the pelvis and span two joints. So this is muscles that move both the femur and the lower leg, or muscles that articulate the hip and the knee. And I have broken these down into a slightly different, yeah, that works, doesn't it? Into a slightly different arrangement. You will be seeing compartments a lot. I think the lab manual does, the book certainly does, break it into anterior, posterior, medial compartments. I'm giving you a bit more perspective by breaking them into functions. So muscles where the main action is flexion, muscles where the main action is extension. And a lot of the time, the main function overlaps with the compartment. Sometimes it doesn't. So just to give a bit of perspective and a different point of view, perhaps, for when you're studying. So hip flexors of interest. First and foremost, iliacus plus psoas major. Make iliopsoas, this large muscle highlighted here. Now is that just bad? Is that too small? I'm going to try going through it this way, and then if we have to, I'll put the information up, and then we'll switch back and forth to a full screen view. Iliopsoas, this large muscle made up of two individual muscles. Psoas major is the one shown on the right here that originates from the bodies and the transverse processes of the lumbar vertebrae. And you can see that clearly shown here. Bodies and transverse processes of the lumbar vertebrae. That meets up with iliacus, and its name gives away a lot of its position, its origin. Iliacus originates along the iliac crest and the entire iliac fossa, the inner surface of the ilium. Those two meet together and then combine into the iliopsoas muscle, one singular muscle that then moves into the leg and attaches to the lesser trochanter of the femur. So take a look at the pathway of this muscle, this combined muscle, over the anterior surface of the pelvis. And then you'll have to imagine, I'm not going to take all the muscles away, but imagine it inserting on the lesser trochanter of the femur. And then when that muscle contracts and shortens, the hip flexes, it moves anteriorly. Now these hip flexors and a lot of the muscles in the anterior compartment all share the same innervation. All share the femoral nerve as their innervation. And the femoral nerve is the nerve that splits this muscle in two. one of the major nerves coming off the lumbar plexus, delivering innervation to the muscles of the thigh, and you can see that it splits shortly after it passes through Iliopsoas. But even after it splits, it's still the femoral nerve. They're just branches, muscular branches of the femoral nerve. And those will come into play shortly when we talk about some of the other flexors of the thigh. So that, I would say, is our main hip flexor, Iliopsoas. There are other muscles that do flex the hip. This is our main hip flexor. When you think about working out your hip flexors or your hip flexor is tight, it's probably Iliopsoas. Other muscles that will flex the hip, first and foremost, Rectus Femoris, one of the heads of the quadriceps, which we know is the main knee extensors. We'll get to those in the next section, but it also has a hip flexion action. Because it spans two joints. It spans the hip joint and the knee joint, so it can articulate both of those joints. Where does it go, or where does it originate from? The anterior inferior iliac spine, one of the main prominences we saw in the ilium, anterior inferior iliac spine, all the way down, like with the other quadriceps, tibial tendon, or patellar tendon. Quadriceps tendon under the tibial tuberosity. But this muscle, being almost completely vertical, in line, obviously will flex the hip when it contracts. And it's complemented by this interesting muscle, sartorius, which has both hip flexion and then lateral rotation abilities. This is the cross your legs muscle. When you lift your leg up and then kick your heel, rotate your heel medially to cross your legs when you're sitting normally, this is the muscle that accomplishes most of that action, because it comes across the thigh anteriorly and obliquely. So this originates just superior, just above rectus femoris, anterior superior iliac spine. And again, femoral or femoral nerve. All the anterior muscles share that innervation. And you can see as it extends all the way down past the knee, inserting just, I'm going to call it lateral to the tibial tuberosity, would have actions of flexing the hip, but also lateral rotation, spinning the knee, pointing the knee outwards as it contracts. And as far as hip flexors go, those are our main players. There are other muscles that will flex the hip, but those are first, second, and third players in flexing the hip. What other actions do we have? Extension of the hip, hip extension. I'm only talking about one muscle here, one muscle of interest, the major prime extensor of the hip, Gluteus Maximus. Gluteus Maximus, big, powerful muscle, one of the biggest muscles in the body. Latissimus dorsi, maybe pectoralis major, maybe trapezius, Gluteus Maximus, one of the biggest muscles in the body. Not only will it extend the hip, it also has some lateral rotation abilities as well. But this is our prime hip flexor. And it originates across a fairly wide area. You see the posterior aspect of the iliac crest, the sacrum, the body of the sacrum, and the coccyx proper. All three regions across the back of the pelvis are where Gluteus Maximus originates. Now the insertion obviously will be gluteal tuberosity on the back of the femur, but you can see there's a little bit of mixing and innervation with this large tract or band of fascia on the lateral side of the leg. There's a little dispersion of Gluteus Maximus as it goes to its insertion. It attaches to the bone directly on the femur to be able to extend the leg proper. And it also has some lateral rotation, abduction effects because of its insertion in this long sheet of fascia. This is the iliotibial tract, or the IT band, as you've heard of it referred to before. That really tight, hard sheath on the outside of your leg that feels rock hard. It's really tight. That makes you yelp when you do one of those foam roller exercises to try to stretch it out. That's the IT band. So the gluteus maximus will activate and abduct the leg through the IT band. So gluteus maximus, easy to remember, its innervation is the gluteal nerve. Always easy when the nerve names are the same as the muscle names. What else? Some of the knee flexors will also extend the leg because, like the quadriceps, some of the heads span two joints, but I'm holding off because that's not their primary action. This primary action extension of the hip joint will be gluteus maximus. What we haven't seen are the adductors. Adductors you spent a lot of time on in lab, and it's easier to see these when we dive a little bit deeper into the muscle, and usually they are all in the medial compartment. Adductors sharing the obturator nerve as their innervation, which I'll come back to in a second. I'm going to look at some of the finer articulating muscles in the pelvis. And if you remember back to the obturator foramen, there was a little gap that I mentioned. The passage of the obturator nerve comes into play there, and I'll show you that in a second. But the muscles in the medial compartment generally all will adduct the thigh. And the most obvious of those adductors, the largest, in keeping with its namesake, is the Adductor Magnus. And this is a really nice view that complements what you saw in lab. The static mannequins don't do a good job of allowing you to manipulate and reveal and remove layers to look at origins and insertions. We saw inferior border of the pubis, inferior border of the ischium, and you could make it out on some of them, but not completely. You get a really nice view of that here. The origin, the inferior border of both the pubis and the ischium, and then the insertion all the way along the linea aspera to the medial epicondyle. Broad insertion, broad angle of action with a lot of ability to adduct the thigh if needed. Many different angles of action. So Adductor Magnus, one of the most easily identifiable adductors I would expect. Longus and Brevis share a similar orientation, and I'm going to remove some of the muscles to give you a better view of them. Longus shown here, Brevis shown just superficial. Both originate on the body of the pubis and have similar insertions as well. If they weren't separate, you could consider them as one muscle with one main action. And we'll call this the medial aspect of the linea aspera. You can see they reach all the way around the back of the femur. Again, contraction to shorten those muscles would adduct the thigh. Pretty straightforward. While I have you here, actually, you know what, let's not jump ahead. Let's continue with the adductors, and then I'll show you the obturator nerve, which I thought was a pretty interesting, or shares a pretty interesting path. The last one is this long, slender muscle that lines the medial border of the thigh. It's not very powerful, as it is a fairly small muscle, but its action would still be to adduct. A similar origin as longus and brevis that we just talked about, the body of the pubis. And this muscle, gracilis, extends all the way down past the knee joint, just medial of the tibial tuberosity. So it won't have much action at the knee because the knee doesn't articulate medial and lateral easily, or it shouldn't. But certainly will help to adduct the thigh, this long, slender muscle, gracilis. Now all of these shared a common innervation, the obturator nerve. And the obturator nerve is this long nerve that you can see here, sending off branches as it passes posterior to adductor longus, and superficial or anterior to adductor brevis. And it has a really interesting origin. Hold on, let me add some connective tissue. There we go. See, it passes just through this very small opening in the obturator foramen. Obturator foramen. Obturator membrane is this sheet of fascia. And the obturator nerve passes through the very small opening, all in keeping with the same namesake. There are some small arteries and veins that pass through there as well. You can probably guess their names, but that's not a major focus of our talk today. So we'll just leave it at that. But while in this area, there are some small muscles that make fine movements at the hip. Lateral and medial rotation that I want to touch on as well. And these are ones that are often contributing to tightness in the hip, feelings of sciatica, or you know that yelp if someone or if you press with your thumb just on the superior part of your Gluteus Maximus, there's some really tight muscles in that area. Some of these really small muscles in that area are responsible for those uncomfortable feelings. And they often, well, they're what I'm going to call intrinsic muscles, and they usually help to rotate the thigh. So that one muscle that makes you jump is piriformis. And piriformis is one of the largest muscles that accomplishes that lateral rotation, one of the small intrinsic muscles of the pelvis, shown here. You can see the largest nerve in the body, sciatic nerve, running immediately deep to piriformis. If there's ever any inflammation or friction in this area, you get a long shooting sensation of numbness or pain in the entire leg. This is one of the biggest muscles, it's the biggest nerve in the body supplying the largest number of muscles in the lower limb. Piriformis you can clearly see inserting on the greater trochanter, obvious on the lateral aspect of the femur here. But its origin, which you can't see until we flip it around to the front side, the anterior surface of the sacrum. So it pops through the back of the sacrum, between the coxal bones and the sacrum, to attach to the femur and laterally rotate. Almost like the rotator cuff of the femur. Now that's going to share the same action with Obturator Internus and Obturator Externus. And it's easiest to see Obturator Internus, and they're named for their origin. Are they internal or external to the pelvis? And Obturator Internus originates inside the pelvic cavity. So you can see this is looking through the pelvis on the interior surface of the ischial bone, of the pubic bone. The entire area is covered by Obturator Internus. It covers the membrane as well, the obturator membrane. The entire interior surface of the pelvis is the origination or the origin of Obturator Internus. You can see it allows a really small gap for the obturator nerve to pass through. And this has one of the most odd and quirky pathways of muscles in the body. It's not a direct point-to-point origin and insertion like many other muscles are. The Obturator Internus leaves posteriorly under the ischial spine and then takes a left turn around the ischial bone, along the bone proper, to insert again on the greater trochanter. So clearly, if it contracts, its job is to laterally rotate. And clearly there must be some bursae to prevent wear and friction and inflammation on the bone itself. But it's a dog leg left if you're into golf. And that's complemented, it's a little bit harder to see with all of these muscles in the way, but this is complemented by Obturator Externus, which is almost the same thing, but external to the pelvis. Very similar origin. Ischial bone, pubic bone, obturator membrane. Passes posterior to the femur. And then inserts on the greater trochanter. Again, lateral rotation of the thigh. We don't often appreciate the tight quarters of muscles in this area and their relationship to the pelvis and the femur and the nerves in the area. Specifically, look at the sciatic nerve as it is progressively impinged upon by all the muscles in that area. Now, before we move on, I also want to take a moment just to highlight an area of interest for you. An area of interest that is frequently susceptible to injury and also is an area that landmarks a few key arteries, veins, and nerves. And that is the femoral triangle. Femoral triangle is this area. I'm pretty sure, yeah, that works pretty well. So the border of sartorius inferiorly, adductor longus medially, and then this long ligament, this long, straight, thin ligament called the inguinal ligament, which connects the pubic bone to the ilium. And it's the point of insertion for some of the abdominal muscles, but it's an inherently weak area. There are no muscles that span across the front of the femoral triangle. And so this is a frequent site of hernias. Whenever there's abnormally high abdominal pressure, 1 rep max or world record squats or deadlifts, things like that, or weak abdominal muscles, playing hockey in your beer league group on the weekend. There's a high risk of herniation in this area. And what a hernia is when there's high pressure in the abdomen, it can push out some of the lower intestines. And what I mean by push out is push under the inguinal ligament some of the intestines. So a hernia shows a bulge on the thigh, an abnormal bulge, and that bulge is intestines that have been pushed beneath this ligament, out the femoral triangle. Common area of injury. We are interested in this area for its landmarking purposes. Femoral triangle contains the femoral nerve, the femoral artery, and the femoral vein. They are obvious within this area of interest. Vein, artery, or nerve, artery, vein. band structure heading lateral from the medial border. This is also a site where in some ex-phys research where you need to run arterial lines, you will run a catheter into the arteries here at the femoral artery. So you have to get the area shaved and all prepped, and you have to have a technician that's really good at pinpointing the artery so that you don't bleed out. Or if you ever have had to have an angiogram, or you know someone that has had the arteries in their heart scoped, you will insert a catheter here, and it will snake all the way up into the aorta and then into the heart muscle from the femoral artery. So a really important landmark. I don't know if I like that. How did this work out with the overlay? After like 5 minutes when we didn't need the other information, it's kind of like I want it to be bigger, right? So maybe what I'll do is give you a moment to copy down the information on the knee muscles, or muscles that articulate the knee, and then I'll put it up full screen so we have a better ability to explore these structures. Luckily, there aren't too many small muscle groups or muscles with small supportive functions in the thigh that articulate the knee. The knee really only flexes and extends. Extenses isn't a word. Flexes and extends. And so these are the usual suspects. The knee flexors and the knee extensors are your hamstrings and your quads. Your hamstrings and your quadriceps. But we know them by their anatomical names: Semitendinosus, semimembranosus, and the biceps femoris in the hamstrings or the flexors section. And then the quadriceps being the rectus femoris and the three vastuses: medialis, intermedius, and lateralis. And I've got a really cool video to show you about the vastus lateralis when we get through this brief discussion, which I hope is going to be brief after having just said that. Now this is also a really nice area as far as innervations go, because the muscles in these compartments share a common nervous innervation. The anterior muscles, femoral nerve. Just like the hip flexors, the muscles on the anterior side, femoral nerve. So knee extensors, femoral nerve. Knee flexors in the posterior compartment, tibial nerve. And all these muscles follow that rule. There might be branches of them, but we'll call them tibial and femoral nerves. So let's explore these briefly. We're going to start with the flexors. And let me just make this bigger. Nope. Nope. That's coming later. Ugh. We'll get it, don't worry. Yes, exactly, that one. Now make it bigger. Okay, I'm just going to put it central. How about that? I was wondering when I'd have like my old guy moment where all of a sudden all technology stops working for me. I wonder if this is it.
Full screen option.
Yeah, where do you see that?
Go back to where option.
Let's do that. There we go. Show me full screen. Let's do it. Oh, that's beautiful. Look at how full screen that is. Okay, anyways, we're gonna persevere. We are gonna persevere. Okay? This is so much better than before. Don't even question it. All right, so we have flexors of the knee. Let's get rid of these gluteal muscles. We don't care about those right now. Flexors of the knee. Medially, the semis. Laterally, the biceps. And semitendinosus and membranosus, I always remember as tendinosus on top. Tendinosus on top. So tendinosus, most superficial, which I have shown here. Almost all of them originate from the ischial tuberosity. Almost all of them, with one minor exception. And the medial, the semis, insert both of them on the medial aspect of the tibial tuberosity. So they loop around the medial condyle of the knee, but ultimately their main action is to flex the knee. And we see semitendinosus, this large over-exaggerated muscle here, and beneath it, semimembranosus, with very similar origins and insertions, both innervated by, anybody? Tibial nerve, fantastic. Now these are complemented laterally by the biceps femoris. The most obvious head of the biceps femoris is the long head. It's the only one that you can see superficially. And this one shares the same origin, ischial tuberosity, but it inserts laterally on the head of the fibula. So you can see it inserting here through the biceps tendon, right onto the head of the fibula. Now, these two spread apart and open up that fossa, that space in the back of the knee, which will be important coming up. Just notice there isn't much in the middle. There's this small muscle that I'm not even going to highlight because we don't care about it. Now, there are two heads of the biceps femoris. The short head is shown here, and it's the only one that doesn't originate at the ischial tuberosity. The only hamstring that doesn't originate at the ischial tuberosity. It instead originates, we're going to call it the last third or the last half of the linea aspera. Same insertion point as the long head of the biceps. And so all of these act to flex the knee, to bring the tibia and the ulna posterior and up towards the torso. Let's turn our attention anterior. The knee extensors, or the quadriceps. We've already talked about the rectus femoris. We know it has some action to flex the hip, but its main primary function is to extend the knee. I'll say if the hip is stable. All of the muscles of the quadriceps insert through the common quadriceps tendon, which we talked about yesterday, covers the patella, and merges into the patellar tendon, inserting on the tibial tuberosity. All four heads of the quadriceps do this. So we've got that out of the way. And we already know the origin of rectus femoris. Anyone remember that? Origin of rectus femoris? You guys got it? No? Anterior something spine, right? Yeah, you'll figure it out. Anterior inferior iliac spine. Look, you can see it really nicely right here. So prime mover, rectus femoris, to extend the knee. All the vastuses are deep. I'm not going to say technically deep, they're behind. But medialis and lateralis are both fairly superficial. So lateral to medial The vastuses are named accordingly. Vastus lateralis, vastus intermedius between the two, and vastus medialis. Now, for the most part, these all originate on or around the intertrochanteric line. The greater trochanter, the intertrochanteric line, and some of the anterior aspect of the femur. And actually, you know what, that's as much detail as I'm going to go into on their origins. You can see here, after that femoral nerve disperses, these are all the muscular branches of the femoral nerve heading down to innervate the anterior muscles of the thigh. All the muscular branches of the femoral nerve feeding the anterior compartment of the thigh. And so, of course, contraction to shorten these muscles extends the knee. What else did I want to show you about this? I'm going to come back to this open area on the back when we get to the muscles of the lower leg, but I want to show you, because we've just discussed the quadriceps, specifically the vastus lateralis is one of the most common site of muscle sampling in exercise science. And that's the video that I have up here that I'm going to show you. This is the perfect muscle to sample when you want to take muscle samples to measure mitochondrial function or enzymes or a training response. A lot of the ex-phys research that you'll hear about, or biochemistry research in exercise science, is done with samples of this muscle. And the reason for that is it is safe. Easy to access, and it's safe. So just take a look at the nervous innervation nearby. There's a lot medially. There's very little laterally at the vastus lateralis. Well, what about the femoral artery? It sends some tributaries off, but it's protected under a lot of these muscles on the medial portion of the leg. Just like the femoral vein, a lot of vascular supply medially. There's very little risk on this lateral aspect of the leg to hit a nerve, to hit an artery, to hit a vein. And so when you see research that says creatine supplementation increases creatine in the muscle, or 1.2 grams per kilogram of protein increases muscle protein synthesis, or 5 days a week HIIT training increases mitochondrial enzymes. All of those measurements are made here. And all of those measurements are made in a way similar to this. And I'll give you, I don't know if there's too much on the audio side of things, but I will add some audio for you so you can see the process. This is a new adaptation of a percutaneous muscle biopsy technique. Hey, class isn't over. Where are you going? Maybe she had an appointment. Joke's on her. There's going to be a bonus question about this on the final. How about that? So vastus lateralis, you can imagine the orientation of the quadriceps here. Rectus femoris, vastus lateralis, little risk of muscle, artery, nerve damage. And this is a modified, what we call Bergstrom biopsy technique. And basically what it is a mechanical pencil and a guillotine mixed together. So the mechanical pencil gets shoved into your muscle, through the skin, through the IT band, into the muscle proper. And it's got a little opening on the tip. And that allows the muscle to go inside that opening in the mechanical pencil. And you have an inner section that's got a really sharp razor blade point or circular edge to it. And you just snip the muscle. And you turn it and you snip the muscle. And it's not as painful as it sounds. This is a modified version, and so let's just take a look at that now.
It's going to puncture the fascia. There. You okay? You sure? That's it. Well, I didn't feel the fascia. Didn't feel it. Well, I have to commit. I trust it. I definitely felt resistance, and then I went through. But you know what? Can you hear me? There we go. Okay.
Oh, that's not it.
I think we're going to do two certain methods with the minor function. Well, we'll take half in. We'll still do half. Okay, sir. Here we go. Okay. Feel good?
Not bad, huh? And the reveal. Much, much nicer than the mechanical pencil I described to you. That one puts a catheter in, and then that little snap sound is essentially the guillotine aspect of it. Much smaller, so it's much less disruptive. I've had 32 of those in my research career. 32. For money, that's why. Nice job. Matt has 9. So when we get that up and running, I'm going to pull you guys to be subjects in a study coming up, and then...
I can do it.
Yeah? All right. Okay, let's leave it there. There's a little bit of information left over, but that's a great break point for Friday. Have a wonderful weekend.